Good morning. Thank you. I'd like to thank the meeting organizers for the opportunity to participate in this very exciting conference. So Dr. Zeltzer showed us that muscle forces induce preferential periosteal growth during embryogenesis, and I'm going to share some data with you in normal children and children with a variety of chronic diseases to show how important those relationships are during childhood and adolescence. So this slide summarizes the processes at play during skeletal modeling. So as the bone increases from length A to B, there's bone formation on the periosteal surface accompanied by bone resorption on the endosteal surface. And we were very interested in the effects of glucocorticoids and cytokines and other disease processes on skeletal modeling, with the concern that these diseases would result in significant deficits in bone density and geometry. Now, most of the data I'm going to be showing you uses peripheral quantitative CT. I know many of you are familiar with this technology, but what we do is we measure the tibia length. We come back 3% from the growth plate, where we can measure trabecular compartment bone mineral density. This does not have sufficient resolution to look at microarchitecture. We then come back to the 38% site, which is where the cortical cortex reaches maximum thickness, and we can measure the structure of the cortical bone, including periosteal circumference, endosteal circumference, as well as density within the shell. And then up at the 66% site, we can measure muscle and fat area. And then off of the PQCT, we can, with the periosteal circumference measures and the endosteal circumference, we can calculate things such as section modulus, which take both of these parameters into account and provide good measures of bone strength. Now, this study summarizes all the different pieces of bone dimensions and density in 600 healthy children, adolescents, and young adults. And the black dots are the males. The open circles are the males after completion of puberty, and the dark circles are males that are pre and peripubertal. And then red are the females. Now, mind you, these are cross-sectional data, so I need to be careful when I use terms like increases. And the other thing about this slide is that these measures have been adjusted for tibia length, which is very important when you're comparing males and females. You don't want to come to the wrong conclusions about bone geometry just in somebody who has a longer bone. So what these data showed is that during Tanner stages 1 through 4, males have a modestly greater section modulus compared to females, but that by Tanner stage 5, those differences are much more pronounced. This manuscript looked at a variety of different outcomes, looked at the periosteal and endosteal surfaces as well as density, but just focusing some more on section modulus, we then looked at the relationships between bone and muscle. Now, other studies have in childhood and adolescence had concluded that girls have more bone relative to their muscle, but we were concerned that some of those relationships were confounded by tibia length. So the models I'm showing you here are adjusted for age, sex, race, Tanner stage, and tibia length. So first, focusing on the female sex effect, I already showed you that they have lower section modulus compared to males, and then during Tanner stage 5, this becomes even more pronounced, where you have this lower number as well, compounded further by this lower number here. And then we asked, well, what happens if you adjust for muscle? As some of those deficits, or not deficits, lower section modulus explained by lower muscle. And you can see over here when the model is adjusted for muscle that the beta coefficients are attenuated, but that girls still have lower section modulus compared to males, and again, even more so during Tanner stage 5. Now, we also saw some interesting race effects. This cohort was about 50% African American, and in black race was associated with a greater section modulus, again in Tanner stages 1 through 4, but then this difference was dramatically less in Tanner stage 5. And we then were interested if the greater greater muscle mass observed in the black participants contributed to the differences in section modulus, and the blacks still have significantly greater section modulus when you adjust for the greater muscle mass. We looked for evidence of an interaction between sex and muscle and did not find one. So many of you are familiar with the model of racket sports, where you have a significant side-to-side difference in bone mineral content. And this slide shows that our healthy controls have a very modest side-to-side difference, but then the racket players, those young women who participated in racket sports in the years prior to menarche, had very dramatic side-to-side differences, which were less pronounced in the young women who participated in these sports post-menarche. Now, this is referred to as a window of opportunity, but as we think about childhood chronic diseases, we're concerned that this is also a window of vulnerability. So in 2005, the ASBMR convened a pediatric initiative to look at risk factors for poor bone accrual in children with chronic disease. And some of the major risk factors that were identified were malnutrition and malabsorption, immobility and muscle deficits, including neuromuscular disease such as cerebral palsy, and cachexia disorders associated with decreased muscle mass, growth failure and endocrinopathies, so abnormalities in the growth hormone IGF-1 and sex steroid axes, therapies, and certainly glucocorticoids I think get the most attention, and then importantly is the impact of inflammation with TNF-alpha and IL-6 being good examples of cytokines with adverse bone effects. One of the things that's been, I think, our biggest challenge in trying to understand the impact of chronic disease and glucocorticoids is that the children who get the most glucocorticoids are those with the worst underlying inflammation. And glucocorticoids and cytokines have remarkably similar effects on bone. So both glucocorticoids and these cytokines in particular shift differentiation away from osteoblasts, inhibit osteoblast activity, and promote apoptosis. So suppressive effects on bone formation at really every level. And we now know much more about how they impair osteocytes, and then through the rank ligand and OPG pathway activate osteoclasts. Now, at the same time, these same cytokines are real culprits in terms of sarcopenia and muscle deficits, inhibiting myogenic differentiation, stimulating protein degradation, and inducing myoblast apoptosis. And finally, glucocorticoids increase myostatin, which is a negative regulator of muscle mass. So you can see how very much the glucocorticoid and the underlying diseases are tangled up, and it's difficult to distinguish between their effects on bone and muscle. Now, this algorithm was proposed by Frank Rauch and Eckhart Schönau as a way of thinking about muscle and bone relationships in childhood chronic disease. And so they said the first step is to ask if muscle mass is adequate for height. And if it's not, you then ask if the bone mineral content is adequate for the muscle mass. And if it is, they conclude that this is a secondary bone defect, that the bone deficit is secondary to muscle. I think we have to make those kinds of conclusions with great caution, because the effects of cytokine can be directly on bone and directly on muscle. So you can see parallel deficits in bone and muscle through these adverse effects, and it may not be a causal relationship or secondary to the muscle deficits. So we've studied bone and muscle relationships in a variety of chronic diseases. These are very different diseases with different risk factors for bone deficit. So I'll be picking some selected details from each of these to try to help us come to some conclusions about these relationships. We've collected PQCT reference data in over 700 healthy controls, and so all of the data I'll be showing you are expressed as sex, race, age, and tibia length specific Z-scores. For those of you who don't use Z-scores, they're certainly widely used in pediatrics. If a Z-score is 0, that means you're at the median of where we would expect you to be. And for example, -1 means you're at the 16th percentile. So the first disease we focused on was steroid-sensitive nephrotic syndrome. This is the most common chronic kidney disease of childhood, and it's characterized by proteinuria, edema, low serum albumin, high cholesterol, and normal renal function. The good news about this disease is that it remits completely and quickly in response to high-dose glucocorticoids. Children can go into remission within a few days. However, it requires very, very high doses, so 2 milligrams per kilogram per day. Many of you know that glucocorticoids on the order of 5 or 7.5 milligrams total in adults is considered high risk, and so we're talking about really huge doses here. And unfortunately, the disease relapses in the majority of children when the glucocorticoids are reduced, so they get protracted, repeated courses of glucocorticoids over many years. But we think this is the best model of glucocorticoid effects because the disease does go into remission so quickly, and we don't think there's as much of a component of detectable underlying persistent inflammation when they're on the steroids. We published a DEXA study showing that steroid-sensitive nephrotic syndrome was associated with significantly greater whole-body bone mineral content and lean mass, which was a real surprise. These kids had had a median lifetime prednisone exposure of 23,000 milligrams, and they still had significantly increased bone mineral content and lean mass. Now, the thing about glucocorticoids is that they cause obesity, so we felt to help us understand what was happening in the nephrotics, we needed to get a handle on the impact of obesity. Obesity certainly is associated with significantly greater fat mass, but it's also associated with greater lean mass. And so what we showed in this, one of our earlier studies, this DEXA study, is that in otherwise healthy, overweight, and obese children, we used this hip structural analysis to look at the section modulus within the shaft of the femur. This shows really the dramatic relationship between section modulus and muscle mass. But what we showed was that the proximal femur geometry was appropriately adapted to lean mass in overweight children and adolescents. So they did have big bones. They had the significantly greater section modulus that was completely commensurate with the greater lean mass, and there was no effect in this model of fat mass. So we felt we needed to move on to something beyond DEXA to understand why childhood nephrotic syndrome was associated with significantly increased bone mineral content, and it ended up being the case that this greater bone mass was in the cortical bone. So they did have the expected deficits in trabecular bone mineral density that we know so well from glucocorticoids, but they had this really striking increase in cortical density as well as greater cortical dimensions. We've done a lot of work on this. We've now seen this in 4 different diseases treated with glucocorticoids. We believe you have suppression of bone formation and then greater secondary mineralization. But coming back to the cortical area, significantly greater compared to the controls. They had the significantly increased fat mass and fat area and muscle area that we expected. And when you adjusted these models for muscle, you could see that that really did explain the greater cortical area that we were seeing in these kids. Now moving on to something very different is Crohn's disease. So this is unfortunately quite common. It's chronic inflammatory bowel disease that results in abscesses and granulomas and fistulas in the gut. It has an insidious onset, and 85% of children present with weight loss. Growth failure and delayed puberty are common, and it's treated with systemic glucocorticoids, methotrexate, and biologics. And there are population-based epidemiology studies showing increased fractures in children and adolescents. This is a PQ-CT scan in one of the kids in our study, and you can see both the decreased trabecular density and the smaller cortical dimensions, and I picked these scans matched on tibia length. So we felt the best way to try to tease apart the steroid effects and the disease effects was to enroll these kids right at the time of diagnosis. So my staff hung out in the endoscopy suite, and once the kids were diagnosed, we got them into the lab pretty quickly before they received any glucocorticoids, and then we looked at how their bones changed over a 1-year period. So this illustrates the very dramatic trabecular bone mineral density deficit, so nearly 2 standard deviations down. I think the average child at diagnosis of Crohn's disease had a trabecular bone density at the 9th percentile, so shifted very much downward. And then it increased quite nicely during the first year of therapy. Unfortunately, periosteal circumference, which was low compared to controls, decreased further, which we attribute to glucocorticoid effects. The endosteal circumference was increased. That's not a good thing. That represents decreased endocortical bone loss, did not change. Section modulus decreased significantly, we believe, because periosteal circumference decreased. Now, all of this is happening in the setting of significant increases in muscle area. So even though muscle area is increasing, periosteal circumference is decreasing. And what we found is that greater gains in muscle were associated with lesser declines in periosteal circumference and section modulus. So it doesn't completely reverse the progression of the cortical deficits, but at least if you're gaining muscle, it helps slow the rates of the impaired bone accrual. Let me just make it clear, these children's bones are not shrinking. When I say your periosteal circumference Z-score goes down, I just mean that commensurate with the increase in tibia length, you would expect periosteal circumference to expand, and they're lagging. Now, at this point, we had some longitudinal control data. So we were able to look at the relationships between changes in muscle area and changes in periosteal circumference. The blue line is in the healthy controls, and you can see that if you increase your muscle area Z-score by 1 over a year, you increased your periosteal circumference by about 0.3. And this just demonstrates how dramatically this association is shifted down in the kids with Crohn's disease, and that, yes, if you do increase your muscle area, you do decrease the amount that your periosteal circumference decreases. So again, this is a change in periosteal circumference over a change in muscle area over 1 year. Now, those were our data at 12 months. We follow those kids out further, and we're just completing the analyses of these kids when they're 3 years out from diagnosis. And even though their trabecular bone density did increase in the first year, it got stuck. And so we saw no change overall in trabecular density from 1 year to 3 years, although I think it's important to note that even though they didn't change overall, our younger kids, our Tanner stage 1, 2, do seem to be improving. So perhaps there's an opportunity to get in and help those kids recover. Section modulus improved just a little bit and very slowly, and this was not because of any changes on the periosteal circumference, but rather because of contraction and gaining backbone on the endosteal circumference. And we've then noticed that as this was happening, their cortical density was dropping quite dramatically, and so we found that as they gained back endocortical bone and as they grew, their cortical density was decreasing. So we think this process of bone modeling has a lower cortical density. What we were able to do with PQCT is this represents the PQCT scan in an individual kid. You can do something called a concentric peel, where you look at the density and the voxels. And so out on the right, out at the right here, this is the outer periosteal surface. So we have a little bit of partial volume effects here, but then the density across the cortical shell, moving from the periosteal to the endosteal surface, is a little lower in the Crohn's disease, and then much lower along the endosteal surface, which we think is that bone, the relatively new bone they're getting back on that surface. Well, what happened in terms of the periosteum? Unfortunately, nothing. So their periosteal dimensions didn't improve at all over this extended follow-up. And what we found using longitudinal control data and longitudinal Crohn's data is that the beneficial effect of decreasing their disease activity, so we had repeated measures of something called the Pediatric Crohn's Disease Activity Index. Over time, as your disease got better and better, your periosteal circumference did improve as long as you were growing. So the beneficial effect of controlling the disease, really we only saw that that was associated with recovery of cortical dimensions if you were growing, with a significant test for interaction. The flip side of that was that the detrimental effects of glucocorticoid therapy was also potentiated by linear growth. So we feel like during increases in tibia length, there's this, again, this notion of a window of vulnerability that the glucocorticoids seem to have more of an adverse effect on bone accrual, but also a window of opportunity. As the disease activity decreased, we started to see some recovery of periosteal bone. Now, we think the culprit for much of this is TNF-alpha. Mind you, we saw those really dramatic trabecular deficits right at diagnosis before those kids had ever seen glucocorticoids. So that really speaks to the underlying disease, not the steroids. So we wanted to get in and see what happens when you treat them with a TNF-alpha monoclonal antibody. We think is really going to the source of the problem. And so children with very severe Crohn's disease are treated with infliximab. They get a 10-week induction followed by maintenance therapy. And we looked at biomarkers in PQCT, biomarkers at initiation and completion of induction, and then PQCT and biomarkers at baseline and 12 months. And what we found are some pretty dramatic changes, speaking to the importance of TNF-alpha. So their disease activity, as we would expect, dropped quite dramatically. This is that disease activity index, and you can see this marked decrease in 10 weeks. And at the same time, we were amazed to see how much their bone-specific alkaline phosphatase, as a marker of bone formation, took off just within a 10-week period. So what happened over the year? Height did not change significantly. Look at muscle area. It recovered completely. So at diagnosis, they have significant muscle deficits, and by 12 months, their muscle looks just like our controls. Trabecular density was horrible, actually below -2. That just speaks to how ill the kids are. They get infliximab. That didn't improve. Well, what about cortical bone? Cortical density dropped like a rock. We have a 1.5 standard deviation decrease in cortical density. We think that's because there's now this very active increases in bone, and again, perhaps not fully mineralized. And endosteal circumference did come down significantly. We actually, when we look at the raw data, it's not just that their endosteal circumference isn't increasing that much with growth. It actually was coming down in an absolute sense. So they were getting bone back on the endosteal surface, and that was the bone with a lower density. Well, what about periosteal circumference? That's what we really care about, since we think that's so important for bone strength. And unfortunately, despite significant gains in muscle area, really complete recovery of muscle area following infliximab initiation, periosteal circumference and section modulus did not improve at all, even in the kids who were growing, where we thought we had a chance to get in and recover some of that bone. Juvenile idiopathic arthritis, another chronic inflammatory disease, shows a very similar pattern with Crohn's disease. One point we made in this paper, just as a little sidebar, when we were doing this study, another group published a PQCT study in JIA, and they came to the conclusion that those kids had higher bone content than you would expect given how significant their muscle deficits were. We believed that the mistake that they made was that they failed to consider tibia length. And so if you take a JIA kid who's sarcopenic and you compare him to a control with the same muscle mass, that JIA kid will be stronger, will be taller. It's the only way they can have the same amount of muscle as a healthy control. So because the JIA kids were taller, they had greater bone mass. And when we repeated those analyses and adjusted for tibia length, we found they actually had lower bone mass relative to their muscle. So just speaks to the importance of considering body size and tibia length when you do these kinds of studies. Now, JIA is the only study where we've been able to also look at fractures. Obviously, everything I'm talking about are surrogate measures for bone strength, but we did do a study where we took advantage of the General Practitioner Research Database in the UK. Cyrus Cooper had already shown us very important fracture data in presumably healthy children, many hundreds of thousands of healthy children within this large database of 6 million people, and had illustrated how fracture rates are very much sex and age specific. So girls have an increase in fracture rates, peaking here at about 11 years of age, and boys have an increase in fracture rates, much higher increase, peaking at about 14 years of age. So when you want to look at a chronic childhood disease, you need very large numbers in order to be able to do the appropriate adjustments for age and sex. And so within this cohort, we were able to identify nearly 2,000 kids with juvenile idiopathic arthritis. And using longitudinal data with, in some cases, many years of follow-up, we were able to show that JIA was associated with significantly increased fracture rates, even in the adults who had a history of juvenile onset idiopathic arthritis. So we do believe that this failure to accrue periosteal bone and perhaps some of these decreases in cortical density, as well as the recognized trabecular deficits, have important implications. I'm just going to wrap up with a couple other diseases I think have given us more insight. In children with chronic kidney disease, we and others have reported significant sarcopenia in those on dialysis, as well as decreased periosteal circumference and increased endosteal circumference, so significant deficits. And we said, well, let's do a kidney transplant. Let's restore normal kidney function and see what we can recover. And what we showed is very nice recovery of muscle mass within 3 months. They have essentially complete recovery of muscle area on PQCT, but unfortunately their section modulus, which was significantly reduced at transplant, didn't budge at baseline 3, 6, and 12 months. So obviously important implications as those children move on to adulthood with these persistent cortical deficits. Now, everything I've shown you so far is muscle area on PQCT, and perhaps there's other parts of their disease processes where those muscles can't generate normal force. So we looked at muscle-specific force using Biodex isometric peak torque, and what this slide summarizes is that in children with moderate or children with severe chronic kidney disease, 5D is the ones on dialysis, they have a 23% lower muscle force relative to muscle cross-sectional area. So this is adjusted for everything shown here. So even if we adjust for the lower muscle area, they have decreased muscle force. We thought we might see that in the setting of glucocorticoid therapy. We did not, but we did see, again, lower muscle force relative to muscle area in severe Crohn's disease. Now, everything I've shown you is quite depressing, failure to recover, but we do have one disease, as I wrap up, which shows really lovely recovery of bone in children with leukemia after they complete their chemotherapy. So children with leukemia get in very intensive chemo with induction consolidation and then 2 years of therapy with high-dose dexamethasone. We enrolled kids after they were done with all of that. We enrolled them within a year of completing their chemotherapy. This slide is the change in these bone outcomes, mind you, change, and then this is looking at when we were able to get them in the study. So if we enroll them right after they completed their chemotherapy and followed them for a year, this is how much trabecular density increased over the year. And look at this increase in cortical cross-sectional area, really lovely recovery of cortical bone, and this was almost entirely due to expansion of their periosteal circumference. If we enrolled them a little bit later and followed them, the recovery was less dramatic, but it just speaks to the fact that the recovery is happening mostly right after they complete their chemotherapy. And commensurate with the increase in cortical area, we saw this decrease in cortical density. So where are we exactly? We were asked as part of this conference to come up with some questions, and these are mine. What is the mechanism for the lack of recovery of cortical dimensions with recovery of muscle mass in childhood chronic disease? It could be decreased loading, secondary to decreased physical activity, or decreased muscle-specific force that we're not capturing just looking at muscle area. Certainly abnormalities in growth factors, and IGF-1 I think is an important culprit. The glucocorticoids inhibit bone formation on the periosteal surface, and some of our more recent longitudinal data supports that. And certainly osteocyte dysfunction could be a disconnect between muscle forces and bone accrual. I think a really important question is, are these deficits in periosteal dimensions irreversible? And I would submit that if you move into Tanner stage 5 and your pubertal maturation and you have significant periosteal deficits and you're not growing anymore, we don't think you're going to get those back. One question is, will physical activity or biomechanical interventions improve bone modeling in childhood chronic diseases? And then we're also interested in other anabolic therapies that may have the potential to promote skeletal modeling in childhood chronic disease. So first and foremost, I would like to acknowledge the NIH. All of the data that I showed you today were collected with support from the NIH, from the 3 different institutes shown here. I'm fortunate to have many collaborators in gastroenterology, rheumatology, oncology, endocrinology, who've been very important collaborators, and then my other collaborators are shown here. Thank you. Questions?
Yeah, Gerard Garsanti, New York. Have you looked for food intake in the patient with Crohn's disease, and treated or not treated with glucocorticoid, and did you see a change to explain the absence of reversal of the bone loss?
Yeah, so we've looked at vitamin D supplementation, we've looked at vitamin D levels, and we've looked at calcium, but we didn't have more comprehensive dietary measures in our earlier studies. More recently, we've done detailed, multiple, repeated 24-hour recalls, and we are going to look at those, but we haven't yet. We've not been able to show any relationships in these longitudinal studies with repeated measures of vitamin D levels.
Karen Esser, University of Kentucky. I really enjoyed your talk. In terms of the transplant, the kids with the transplants, did you look at so the muscle mass recovered, but did you happen to look at strength?
Yeah, we did. So muscle-specific force, which is the term we use for your muscle peak torque relative to your muscle area, improved, but was still not normal a year out. So again, that may be a really important part of the story. We did publish a paper in Healthy Kids where we took their bone outcome, say section modulus, and if you include muscle in the model with age, sex, race, Tanner stage, and tibia length, you can explain 92% of the variability in bone. When you add muscle-specific force, it is significant in the model, but it changes your R-squared from 0.92 to 0.93. So we think muscle is accounting for very much of what we're seeing. Now that's Healthy Kids. That may not be appropriate to make that leap in children with chronic disease, but yes, they still have decreased muscle-specific force at 12 months.
Have you ever considered, or do you do any grip strength measures? Because this is becoming a great way to get an easy, marker, albeit, maybe not as ideal as some of us in the muscle field have thought over the years. But anyway.
Yeah, we've done radius PQCT and hand grip in a number of our diseases. I haven't looked at those data yet. I've been so worried about partial volume effects when you look in smaller bone, when you look in the radius in these 5-6-year-olds who have growth failure. So we have collected those data, but we haven't done anything with it yet. We really wanted to focus on the muscle loading of the tibia, since that's our primary outcome. That's why we use the Biodex. And we have done some ground reaction force testing, but we haven't analyzed those data yet. Thank you.
Particularly San Francisco, Mary, that was a great presentation. You rolled through a lot of data. But I'm getting, and I want you to comment on this. I got the sense from your steroid sensitive nephropathy that you had a very different picture than when you combined that with a lot of cytokines, as you would with GIA or Crohn's. It looked to me like you had much better recovery, or actually maybe an improvement of muscle and bone when it was only a steroid phenomenon. And I know that's, at least old literature indicates, that's the case for kids who have Cushing's disease. They actually do recover very nicely in terms of bone and muscle. So you didn't make this conclusion, but would you be willing to conclude that the difference that you're seeing between Crohn's and JIA and the steroid-sensitive nephropathy is, in fact, the difference between the inflammatory component, which is not enabling this bone recovery, and just the glucocorticoids themselves?
So for a long time, that's what we've believed. We've believed that the glucocorticoid effect is very different than the effect of the cytokines. Now, it may not be quite that simple, because I showed you the cross-sectional data in the children with steroid-sensitive nephrotic syndrome. We have a manuscript under review with long-term follow-up in those kids. Even though their cortical dimensions are increased associated with a greater muscle area, associated with a greater fat mass, as they grow over time, the more they're growing, they actually start to lose some of that ground in terms of their periosteal circumference. So it may be that there's still an important role for steroids, but certainly it's going to be potentiated by the cytokines, and that's why I put up that slide showing how similar cytokine and glucocorticoid effects are. But in our longitudinal, long-term follow-up of our Crohn's kids, in the same multivariate model, we can tease out both an effect of inflammation and an effect of glucocorticoids. So I think I absolutely agree with what you said, but there may be some subtleties and some overlap that it's not quite that straightforward.
Mary, that was Robert Marcus, Stanford University. Yeah. Mary, that was elegant both in data and in presentation. Thank you. But I would like to raise one caution, particularly concerning your patients with nephrotic syndrome. And that relates to an experience that we had about 15 years ago when we treated older people with growth hormone and with IGF for a year and studied, we thought we were studying lean mass and bone mass. And it turns out that apparent gains in lean mass by DEXA were all explained entirely by increases in water volume. And as you know, DEXA cannot distinguish between water mass and protein mass. And in nephrotic syndrome, where both plasma and intracellular water are already expanded, you're surprised that lean mass was in fact increased raises a red flag to me that in fact that you could just be dealing with a hydration issue.
Yeah, no, I couldn't agree more. I didn't have the time to go on a lot of this. To get into the study, you had to be in a documented remission with a normal serum albumin level for 2 weeks. So I don't think those nephrotics have edema, significant edema, and their muscle-specific force was normal. So the amount of force they could generate relative to their muscle area seemed to be preserved.
I've never seen any data on intracellular water in nephrotic, at least adults, who have been in, quote, clinical remission. It may be that that's completely normal. On the other hand, remission doesn't mean cure, and they could also, it still could be an expanded fluid compartment in cells, not related to extracellular edema, but intracellular.
No, that's a point well taken. I do think because their greater muscle areas seem to explain their greater bone, and because their muscle-specific force was normal, we're hoping that it's not, that these measures aren't compromised to too great an extent by that limitation. Thank you.